Yes, sir.
Perfect. Thank you very much. So I think many of you must have seen this module because recently I have taken their same thing for Parul University. Okay, because they have requested before this class, they have requested to talk over, heart attack, and I have taken the same module there. So, it's a good repetition, it's a good revision for the people from Parul University if they want to, revise. And this is module 4 actually for our cardiology season 1, series 1. And today's class is on myocardial infarction. Okay, so today is fourth module, and today we are going to discuss about myocardial infarction. And along with that, there will be two classes on myocardial infarction, one today and one next Friday, because myocardial infarction is not a short topic, not a small topic, right? And then again on cardiomyopathies, there will be class. So that's how we are completing 6 or 7 classes, as I told you. So today I'll be taking a class and the basics of myocardial infarction, and the entire therapy I'll take in the next class. Okay, the therapy for myocardial infarction in different myocardial infarctions, because there are the types of heart attack. There are the types of heart attack. So based on the types of heart attack, there are the different therapies, different treatment policies. I'll be taking those thing in the next class. But today there is no live streaming because we can accommodate. See, out of 800, only 200 or 150 are joining. So why to go live on YouTube? I'll be sharing the recordings on YouTube. My team will be editing this and sharing on YouTube. I think there is no need to go live because there are unnecessarily, unedited videos, that we cannot edit. I think online there are certain things. So, attend the class live, talk to me here in YouTube. You cannot even talk to me. You cannot even, discuss properly. So attend the classes here because we have the occupancy of 1,000 people in Zoom. So we can conduct the classes here and share the recordings later in, YouTube. That's not a deal, I think, for every one of us, right? So I suggest all of you to put your mics off and ignore the background noise here, guys, because here it's heavily raining. Okay, so please avoid the background noise. Okay, so let's start. Today we are going to discuss the myocardial infarction, and we will start with a case. This case is amazingly interesting, guys, amazingly interesting. Okay, and this is one of my favorite case because it will tell you all the aspects, all the descriptives about the myocardial infarction, and you all can unmute yourself and please answer. I don't want just to teach and go. Okay, I want all of you to contribute, all of you to answer, because see, myocardial infarction or heart attack is not a tough disease to understand. Everyone knows, because this is the second highest, second highest non-infectious disease in the world, which causes the mortality. Okay, which causes the mortality. Highest, second highest non-infectious disease to cause the mortality in the world. Okay, so you can, after cancer, heart attack is the second highest non-infectious disease to cause the mortality. So everyone knows, the basics somewhat, somehow, about the heart attacks, about the myocardial infarction. So you can easily answer, you can, easily interact, and you can tell me the, whatever I'm asking, right? So let's start. Okay, so this class is, this is the disclaimer. As we discuss always, this is a real-time case from one of the reputed institute. We cannot say the name, but where I work, this is from there. And this is a very interesting case, live case, right? So we are going to discuss, as we discuss in the case presentation, diagnostics, and the learning points, treatment algorithm. We are not going to discuss today. Okay, treatment algorithm we are not going to discuss today, and prescription audit, discharge plans, we are going to discuss in the next class. So today we are going to discuss the case presentation, diagnostics, and learning points. That's very important, including ECG, including the basics of ECG also. That's very important for all of you, all of us, right? So let's start. Understand, try to understand and answer the questions. Follow me, answer the questions. Let me put it on the presenter mode. Yeah. Okay. So here we are talking about a 42-year-old woman presents to the emergency room with the 8 by 10 substernal chest pain and pressure radiating to her jaw that has been occurring for last 12 hours. Okay, last 12 hours. Her uncle died at the age of 54 years due to cardiac arrest. Her uncle died at the age of, everything is very important here. Try to understand, try to correlate from now itself. Her uncle died at the age of 54 years due to cardiac arrest after 3 years of angioplasty to LMCA. LMCA, here I'll tell you, LMCA is left main coronary artery. So there are many coronary arteries in the heart. I mean, all the arteries or veins are called coronary artery, coronary veins. Okay, except pulmonary thing, except the pulmonary phenomena, because there is we know the ulta phenomena, we know the opposite phenomena, because their arteries carry the blood, carry the blood which is impure, right? And veins carry the blood which is pure, right? So there is a ulta phenomena in case of pulmonary, but all the arteries in the heart are called as coronary arteries. Okay, so LMCA is the main coronary artery which is distributing the blood, which is distributing the nutrients to the left side of the heart. That does not mean, see, LMCA does not mean the artery which is sending the blood, or which is sending the blood to the heart chambers. No, this is the artery which is getting the blood from the heart and sending it to the heart wall. Because heart wall also need the oxygen, heart wall also need the nutrients to pump, to contract, to relax, right? So that's how it works. So the coronary arteries are the arteries or the veins which are supplying the blood to the heart as an organ, not to the chambers, right? To the heart wall and the different parts of the heart, right? So here in this patient, in this patient's uncle, he underwent the LMCA angioplasty before the death, 3 years before the death. Okay, so here it is clearly mentioned, remember this, that the patient had a family history. Patient had a strong family history of death due to heart attack. For that, the patient's uncle underwent the angioplasty at the age of 51 years. Understand 51 years why I'm telling? Because patient's uncle has died at the age of 54 years after 3 years of angioplasty. That means the angioplasty was done at the age of 51 years when he got the heart attack, when he got the myocardial infarction, and he underwent LMCA, right? So strong paternal family history is there, right? Then she has been started on atorvastatin and fenofibrate for her increased lipid levels 8 months back, and taking metoprolol 25 mg daily in the evening for hypertension for past 18 months. Okay, so the general question, how many can how many of you can answer this? What are the risk factors here for the for the myocardial infarction, for the heart attack in this patient? How many risk factors this patient is carrying carrying for the heart attack, for the myocardial infarction? Just a general question for all of you.
Hyperlipidemia.
Hyperlipidemia.
Hypertension. Family
history.
Hypertension.
Family history. Genetic. Okay, family, that's not genetic, that is family history. We call it family history, not exactly the genetic.
Hypertension.
Yes, hypertension, hyperlipidemia, right?
Genetics.
So yes, these three things are the major risk factors. These three things are the major risk factors. First, hyperlipidemia. Second, the family history, and the hypertension, right? Now, if you know, I'll come to those things. If you know, what are the typical symptoms of myocardial infarction? What are the typical symptoms of heart attack? Anyone?
Radiating pain.
chest pain,
Radiating
Chest
pain.
Radiating chest pain.
Radiating to left side.
Okay. Radiating to the left side. Okay, great. So the chest pain which is radiating to the left arm, left shoulder, or left jaw.
Biomarker.
Yes, left jaw. Okay, no, I'm just asking the typical symptoms, not the biomarkers right now, Manish. Okay, we'll discuss that one by one. We'll discuss that one by one. We'll not confuse. So one by one, like, yes, the typical symptoms are angina, which is called chest pain. Okay, chest pain, and which is radiating, the chest pain is radiating to the left side, left arm, left jaw, or the left shoulder. Okay, then heaviness of the heart, breathlessness with kind of suffocation. Okay, with kind of suffocation, right? Understand, these are the major typical symptoms of heart attack. These are the major typical symptoms of heart attack. Understand? Okay, now the lady is just 42-year-old. Remember this, keep in the mind. Okay, let's go to the next slide. So now what should we do now next? Yes, what's your next take? After looking at this case, what's your next take? How and how we should go further? What should we do?
ECG.
ECG. Okay.
2D echo.
2D echo. Okay. Okay. So don't you think that we should go for the vital checks and anthropometric?
Yes.
That's the primary thing. That is the primary thing. When the patient comes to you, you should always check the anthropometric and vitals, right? So the patient had the weight of 70 kg, height 167, so BMI was 25.1. Is it normal or abnormal? What do you consider?
Slightly abnormal.
Yeah, it's slightly abnormal. It is like kind of overweight but not obese, right?
Borderline.
It is borderline because what is the range of BMI?
17.9 to 24.9.
24.9.
Yes. So 17.9 to 24.9. I mean 18 to 25 usually we can say they like but I mean there is another check, right? There is another check. This is the general thing what we read in the books, but for the diabetes we read the ASEAN guidelines for the diabetes. Okay, ASEAN guidelines for the diabetes, and they have divided our South Asian population into different parts. Okay, they have divided, right? And that division, that classification says something else. According to them, 17 to 23 is normal, 23 to 28 is overweight, and 28 to 30 is obese, and more than 30 is I mean obese grade 2, right? They have different thing that we are not going to discuss here, but the normal is 17.9 to 24.9, as we are saying. For heart attacks, I mean that is for diabetes what I'm talking about. Okay, so for heart attacks, or for normally, we consider that 17.9 to 24.9, and this patient is slightly at the borderline, kind of, we can say, oh okay, little overweight, right? And then temperature was normal, blood pressure was suited up to 170/94, so definitely very high. HR was quite high, 100 beats per minute. RR, respiratory rate, was normal, almost normal, and then no neurological symptoms, and pickle. Okay, so what is pickle, guys? Someone can explain pickle?
Paler icterus clubbing.
Okay, pallor,
Edema,
icterus, clubbing,
lymph nodes,
cyanosis, lymph node,
Edema, lymphadenopathy.
lymphadenopathy. Exactly.
Edema.
So here P reflects the pallor. So what it means?
Yellowish of skin. Skin become yellow in color.
Okay, what are the indications?
Yeah.
Low HB.
Yes. Anemia.
Absolutely. I mean, the indication could be towards anemia. So, okay, let's go to the further investigations. What we have done, further investigations here. Look at this. Okay, look at the further investigations, guys. Okay. So, further investigations. Serum creatinine 1.4, slightly high, because usually we consider from 0.6 mg per dl to 1.2 mg per dl for normal. right? But here serum creatinine is slight high, 1.4. So it could be because of the different reasons it could be. Why? Because when the patient came to the hospital, patient's angiography was done, and we use the contrast, we use the dye when we do the angiogram, okay? And that contrast usually suit up the creatinine because it does not clear easily through the kidney, right guys? So it is 1.4, slight high, definitely it is slight high. And then total cholesterol 180, LDL 236, which is really high. So that's why we are calling the patient hyperlipidemic, okay? That's why we are calling the patient hyperlipidemic. HDL is okay, normal. TG 386, again very high, right? What is the normal range of TG?
Less than 150, sir.
Less than 150.
What's the normal range of total cholesterol? TC?
150 to
Less than
200.
200.
Less than 200. Okay, right. And now look at the downside, right corner, sorry, left corner here. So what do you understand by this? Tell me one by one. What is CK?
Creatinine kinase.
Kinase.
What should be the normal limit for creatinine kinase? Guys, come on. It should be on your tip of tongue. What should be troponin T normal? Everyone is Googling.
0.05.
0.1 to 0.4.
It is about troponin T. What about CK? Creatinine kinase.
100 to
5 to
120.
25.
Okay. I mean, we can say it is quite high. CKMB is CK is very high, creatinine kinase. And troponin T is at least 10 times higher than the normal. 10 times higher than the normal. Okay. Why it is normal with the book, with the rule book, it is, it should be less than 0.1. Oh, sorry, 0.01 to 0.04, as someone told, right? So 0.01 to 0.04, it should be the normal, right? But usually in the cardiology, when the patient comes to confirm the heart attack, to say that, okay, very, confidently to say the heart attack, we usually consider 0.1 nanogram per ml, okay? According to the guidelines also, because sometimes it is false negative or false positive, so we usually take at least 10% higher. Now it is 100 it is 100 times higher of the normal range, which is 0.01 to 0.04 ng per ml, right? It is almost 100 times higher, but usually we take 10 times higher, which is 0.1. okay, if it is less than 0.1, then we do not go for the direct check. We usually go for the angiogram. Definitely in all the cases we go for the angiogram, but usually we are not confident enough. Okay, we are confident enough for the heart attack when the troponin T goes more than 0.1. Understand? 0.1. Okay, so what about variation of troponin values with respect to time of attack? Okay, see, usually troponin T, the half-life of the troponin T is 4 to 12 hours. Okay, 4 to 12 hours. So it is in the blood, it is in the circulation for up to 12 hours. The peak what I'm talking about is peak. Okay, so if the patient is reaching to the hospital within 4 to 12 hours, usually early hours, then the troponin T is quite significant. Okay, usually troponin T is not going down even after 24 hours sometimes, but the peak hours are 4 to 12 hours. Okay, if you are reaching to the hospital and checking troponin T or troponin I is a different what we say is different type of troponin, because troponin T sometimes is not available everywhere, but troponin I kits are cheaper than troponin T, and these are available usually everywhere. So troponin I also we can check, and troponin T is usually not available everywhere, but when you go to the tertiary centers or secondary care centers, then you get the troponin T to do. And That's the range. You know, we usually consider more than 0.1 nanogram per ml. Okay, guys. And CK, what we are talking about, CKMB here is almost normal, but CK is very high. CK normal limit usually we consider less than 150 unit per liter. 150 unit per liter. Okay, 120 to 150, different guidelines says different, but it is very high. It is 300 units per liter, right? So here we can say, based on the troponin T, we can definitely say the patient got myocardial infarction, right? Patient got the myocardial infarction, right? Now look
Sir,
at
I
the
have a
ECG.
question.
Yes, please, Varsa.
Sir, you mentioned in the earlier slide that we have used dye due to which creatinine value will change. It will fluctuate, right?
Contrast, yes, dye.
Yeah. So if we do it without dye also and with dye, so we will get the proper creatinine. So can we do that when a patient is coming?
No, we cannot do the angiogram without contrast, because contrast is the only thing which will show us the exact location of the block, which will show us the exact size of the block, size of the plaque.
Okay. Okay, so we cannot do plus or minus thing if, like, we all know.
No. Because see, this creatinine, okay, I'll tell you one more thing. There is one more thing called CIN. Okay, remember this term CIN, that is contrast induced nephropathy. Okay, that is easily reversible. Reversible means, you know, when you are only tell us the way where we are going, where we are putting the stent. That is the only thing where we can, that is like visible during the X-rays, during the angiogram machine, right? That is the contrast which will show us the way to do the procedure. Right? So the contrast can raise the creatinine, and it is reversible. You know, it will take 4 to 6 days, sometimes 15 days to pass on the contrast through your urine, through your kidney, right? It will take some time.
True.
And yeah, okay. So sound quality is not okay, maybe because of rain. So I think someone's mic is also on. You can keep off your mics. Only, put your mics on if you are speaking. That is my request to all of you. Okay, because of the other people's mic also, it is creating some kind of noise in background. Okay, so I hope it's
what
clear.
is the normal value of CK?
Yeah, thank you.
Sorry.
120 to 150.
Okay, CK is somewhere 120 to 150 units per liter. Yes. Okay, so we have here CK is very high, and troponin T confirms the heart attack. Troponin T confirms the myocardial infarction. And guys, troponin T only secretes when there is the infarction. Infarction means there is the injury of myocardium. Myocardium is the layer, the lumen of the coronary artery. Okay, myocardium is the lumen or the insider wall of the coronary artery. When it gets injured, then only the troponin T comes out. Troponin T secretes. So it confirms here that the patient has the heart attack. Okay, and to look that in which reason it is, or to confirm with the ECG, I mean, because troponin T takes 3 to 4 hours to get the results. I mean, nowadays troponin I is quick. It is bedside test. You can just take the blood, you can put in the kit, and in 5 minutes you will get your troponin I results. Okay, nowadays troponin I kits are easily available, but troponin T takes time. Troponin T takes 1 to 4 hours. 1 to 4 hours to get the results. So by the time you can confirm by the ECG. So ECG is the first diagnostic tool for the heart attack patient, for the patients who have for the patients who have angina or who come up with the chest pain. Okay, so here you can see the ECG. Okay, first read the text here. Sinus rhythm means normal rhythm with small Q waves in the lead 3 and AVF, with T wave inversion in lead 2, lead 3 and AVF, and ST depressions in V5 and V6. Okay, unknown. Okay, this is something tough for you. I'll make it easy. So this ECG is 12 lead ECG. Okay, this ECG is 12 lead ECG. Nowadays there are 6 lead ECGs, there are 3 lead ECGs, there are 4 lead ECGs also. Okay, available. I mean, in the primary care centers, or in the clinics, usually they cannot afford the 12 lead ECG, or they don't know how to read the 12 lead ECGs. The doctors who are sitting in the primary care centers, so they keep 3 leads or 4 leads because they that is easily available and easy to place on the patient. So it is easy, right? So that's why there are different types, but the normal ECG is 12 lead, and this ECG is 12 lead. So here you can see 1 2 3 4 5 6 7 8 9 10 11 12 leads. Okay, first, second, third lead, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. 12 leads means the knob. Okay, the knobs of the ECG leads, wherever they are placed on your body. Okay, based on that, it senses the conduction system, and wherever it is disturbed, it will show in the ECG, right? So here you can see easily on the second and third. See, first let's understand the normal ECG. Okay, this you can see the first. This is normal. Okay, this is normal. There are the waves like it starts with here. If you look at this, or let me show you first the comparison. Then I'll come back to this. Okay, I think okay. So this is the learning point 1 for all of you. Different types of ECG. Okay, different types of ECG. Look at the normal ECG first. This is P wave. Okay, this is the P wave. This is Q, R, S. Okay, this is the S. This is R, this is Q. P, this is P, Q, R, S, and T wave. This is T. Okay, and this segment between S and T, this is called ST segment. Okay, this is called ST segment. And this wave, this is called as QRS complex. QRS complex. This is QRS complex because QRS complex. Okay, this is called as QRS complex, and normally it looks like this. First it goes down inward and then upward, and it is totally normal. Okay, this is a normal ECG. Okay, so it starts with the P wave, which is short. Okay, which is short, and then it is a segment. It is called as QRS complex, and then it goes to the T wave. Okay, and the segment between S and T is called as ST segment, which is normally flat and parallel to P to T, or the space, or we call it TP segment. Like, this is a normal phenomenon. This is a continuous phenomenon. So after T, again the P will start here. Okay, after T, the P will start here, and again the QRS complex will come and the T will come. Okay, so usually this segment is called TP. So this ST segment should be parallel to TP segment. Okay, which is the longest segment. So here you can see this is the parallel. Okay, this is the parallel segment, and that is called normal ECG, where P is normal, ST segment is normal, ST segment is normal, T is upward. Okay, in the normal ECG. But there are different types of myocardial infarctions based on the ECG. I'm talking about based on the ECG. Otherwise, there are 4 types. Stable angina, unstable angina, anstomy, STEMI. But based on the ECG, there are 2 types. One is STEMI, one is anstomy. So STEMI means like where ST segment is elevated towards towards upside. One sec, guys. Okay, so this is normal, and when it is STEMI, that means ST segment is elevated. Okay, you can see here the ST segment is not parallel to TP segment. It is upward. Here you can see in the STEMI, it is upward. ST is elevated. Okay, ST segment is elevated. But in anstomy, there are 2 phenomena. Okay, in anstomy means non-ST elevation. Okay, non-ST elevation, that means ST is not elevated. When ST is not elevated, that means there are other two phenomena. Either ST is depressed means going downwards, okay, going downwards, or the T itself, ST is normal but T is inverted. T is not upwarded, T is inverted here, okay. T is inverted, you can see the T is inverted, that is called T inversion. That is called ST depression. ST depression means ST is going down, right? And here in stomy, I mean this ST segment elevation MI, it is upward, that is called complete ST segment elevation, that is called ST elevation. And here it is called, I mean in anstomy there are two phenomena. One is ST depression or T inversion. ST is normal but T is inverted. T is inverted. So this is the normal phenomena of, you know, differentiating the myocardial infarctions. Okay, this is the basic. I mean there are many others, but this is the basic to differentiate. Usually when the patient has typical stomy or inostomy, you can easily check out. This is the normal. ST will be normal parallel to TP, okay, parallel to TP segment. And if the patient is having STEMI indicates that ST is elevated, ST elevated MI. Anstomy means there is no ST elevation, non-ST elevation MI. But there are two different other phenomena. One is ST depression or T inversion. In either case, you know, something will be going down, whether it is ST or whether it is T wave itself. Okay, so you understand that. Now go back to our patient's ECG and check how does it shows. Okay, see, look at the second and third wave. Here you can see easily T is inverted. Okay, T is inverted. Here QRS in okay, I'll say one more thing. In usually second and third, PQRS, I mean the QRS complex is not prominent, okay, but the T is usually normal. But here see, in the first you can see T is normal, right? T wave is normal. Here look at the second and third wave, okay, third and second, the T is inverted, right? T is inverted. You can see the T is inverted here, right? T is inverted. And look at the 5-6, V5, V6. ST is depressed. ST is going down. ST is going down. It's not only, see, it is not only T, it is ST. Look at this. See, it is not parallel to P. The entire ST is depressed. Okay. So what kind of MI this is? What kind of MI this patient is carrying now?
Anstomy.
Exactly. This patient is having anstomy. Yes, guys. Yes, you are pro now. So the patient is having anstomy, right? Okay. So, I mean, you must have seen this, but still, I would like to ask you, what is the provisional diagnosis for this patient according to you?
Hypertension, dyslipidemia, acute coronary syndrome.
Okay, so inferior wall MI. Dr. Vikas, interesting. On what basis you are telling this is inferior wall MI? Tell me.
Lead 2-3 AVF is affected, are indicating,
okay.
Yeah, and I am not much clear about the ST depression in V5 and V6. I don't know it's posterior wall or not.
Okay, let it be. Let's not touch inferior or posterior, parallel or lateral. Okay, lateral wall MI are there, but okay, that we'll discuss. Okay, that we'll discuss definitely. But this is not exactly the inferior wall MI. Okay, this is inferior lateral. Okay, so the provisional diagnosis is first dyslipidemia because patient is already on atorvastatin, and we have seen the patient's TZ levels and LDL levels, right? Hypertension, definitely yes. Acute coronary syndrome. Why it is acute coronary syndrome? Guys, can you tell me why it is acute coronary syndrome? Can someone differentiate acute coronary syndrome and coronary artery disease for me?
Acute coronary syndrome means All over the heart condition, including angina to MI.
I mean, this is the normal phenomena for all coronary artery disease, for all myocardial infarction. What is the difference between coronary artery disease and acute coronary syndrome?
Coronary artery disease.
Acute coronary syndrome is a suddenly and short term.
Okay.
Sir, any condition in which there is sudden reduction in blood flow to the heart that lead to acute coronary syndrome, and in cardiac. Sir.
In case of
Okay.
coronary artery disease, there is formation of plaque.
Okay. That's normal. That's in all the coronary artery disease. Okay, let me tell you guys. Acute, as it says by the name, it's acute. There is certain limit of time. And this is a part of coronary artery disease. Okay, this is a part of coronary artery disease. Coronary artery disease means it could be acute or chronic. It doesn't matter. Acute coronary syndrome is something which is newly onset. Okay, newly onset means usually there is no certain time limits which is defining in the rule book or the guidelines, but usually they say it should be within 24 to 72 hours. Okay, within 24 to 72 hours. Okay, but usually we take up the acute coronary syndrome when the patient has anastomy or istomy, that is acute coronary syndrome, with the high troponin T's, with the high biomarkers. That shows because, as I'm telling, biomarkers says the acuteness of the condition. Okay, so acute coronary syndrome is the early onset, or we can say the acute onset of the symptoms, acute onset of the disease, right? Usually 12 hours, 24 hours to 72 hours in case of that. And there is the chronic stable anginas also. Okay, chronic stable angina that I'll discuss in the next slide. So acute coronary syndrome means the acute onset of the symptoms, and this is one of the part of coronary artery disease. Coronary artery disease includes all type of ischemic heart disease, whether it is acute or chronic. Okay, so the provisional diagnosis here definitely dyslipidemia, hypertension, acute coronary syndrome, and there are certain things which we should keep in mind. That one is raised creatinine. That could be anything. We have to define it. What is exactly this 1.4 creatinine saying? Okay, and then lower hemoglobin and pallor. Why it is? We have to go for further evaluations. Okay, these are the other discrepancies to keep in mind, but the final diagnosis we still have to make, right? So after that we go for ECG. ECG says that this patient has an istomy, as we all decided. Like after looking at the ECG, we all decided this patient has an istomy, right? So now learning point 2 for all of you: different coronary artery disease and ACS. So look at this. There are 3 rows. One is acute coronary syndrome and CAGs showing, and based on ECG and troponin T. Okay, troponins. So first is stable angina. Okay, first is stable angina. Stable angina. One sec, guys. I'm getting a call. So sorry. Okay, guys. So yeah. So this first is stable angina. Stable angina means, see, look at this picture. Look at this picture. There is some kind of stable atherosclerotic plaque. Means plaque means maybe due to the calcium, foreign particles, or the fat substances, free fatty acids. Remember this, fat substances or calcium or any kind of foreign particle in the blood that can cause the damage or injury to the wall, to the myocardium, and because of that there is a stable atherosclerotic plaque. Stable means that is not moving and that is not even ruptured. Okay, there is rock solid stable plaque which is just restricting the blood flow. Okay, which is just restricting the blood flow and restricting the oxygen supply to that specific part of the heart, because we are talking about coronary arteries here, right? We are talking about the coronary arteries. So this is angina. Pain develops only when there is increased demand in the setting of a stable atherosclerotic plaque. The vessel is unable to dilate enough to allow the adequate blood flow to meet the myocardial demand. So this plaque is not moving, but it is restricting the oxygen flow. It is restricting the blood flow. So the demand of oxygen is not meeting, okay, the supply. Okay, that's why the pain is occurring. That's why the pain is occurring, and that is called stable angina. Usually that pain is occurring when the patient is exerting himself or herself, like they are walking, running, they are working, they are lifting weight, they are they're working hard in the fields, or they are working hard, they are taking a lot of stress. I mean, whenever the criteria of supply and demand is not meeting, then the chest pain is occurring, because due to this stable plaque, the oxygen supply and demand is not matching. Okay, and that is happening due to high stress, due to heavy workload, due to running, due to exercises, due to anything it could be. But it usually gets normal when the patient goes for rest. Patient is taking rest. Okay, in this case ECG will be perfectly normal and your troponins will be normal. Now you will ask, what is the diagnostic criteria? Because very important, patient is getting chest pain, frequent chest pain, whenever they are working, whenever they are doing whenever they are exerting themselves, they are getting chest pain, but they're not getting in the ECG, they're not getting the troponins high. So how to diagnose? In that case, we go for treadmill test or stressed echocardiogram. Okay, understand? Treadmill test or stressed echocardiogram. Treadmill test means when we allow the patient to run on the treadmill at different levels, from the basic level to hard level. Okay, someone's mic is on, guys. Okay, so we allow the patient to run on the treadmill and then we measure the ECG. That time the ECG changes comes in the treadmill paper. Okay, in the treadmill report. Okay, that time we check the exercise tolerance. Okay, and based on that we find out and we suggest whether the patient has to go for angiogram or not. Okay, so in that case where the patient has the stable angina, patient gets the chest pain, but ECG and troponins are normal, then go for either stress echo or treadmill test, exercise tolerance test. Okay, next is unstable angina. Unstable angina, of course, sometimes your ECG is normal or your T wave is inverted or ST is depressed. Okay, ST is depressed, ST depression is there. I mean, kind of meeting the anstomy criteria, but troponins are normal. Okay, ECG shows the criteria of anstomy, but troponins are normal. Why it is happening? The plaque is ruptured now. Plaque is ruptured now, and the thrombus is there, which is made around the ruptured plaque. Okay, you can see this. This is ruptured plaque. Okay, and ruptured plaque are made of platelets, calcium, okay, and other blood components, and the fibrin, fibrinogen. Many things are there that we'll see in the pathophysiology part in the next slide, right? So this is like causing more restrictions to the oxygen supply. Here, the plaque ruptures and a thrombus forms around the ruptured plaque, causing partial occlusion of the vessel. Angina pain occurs at the rest also. Here, it is occurring at the rest also, or the progress rapidly over a short period of time. So it can happen within seconds to hours. Okay, unstable angina can happen within seconds to hours, right guys? Remember this. In this case, your ECG may have the changes, but troponins will be normal. That is called unstable angina. Okay, and it can happen from seconds to hours. That's why it comes under acute coronary syndrome. I'll tell you. Okay, and then third is anstomy. You know, here we will definitely have the T inversions or ST depression, and troponin T will be elevated. Here, the complete, not complete occlusion, but the partial occlusion will be having. Okay, and this thrombus, thrombus will be, even running around. Thrombus will be running around. So here you can see subendocardial infarction is here. Okay, subendocardial infarction is here, and the blood flow is restricted. In that case, ST depression, T wave, T wave depression, T wave inversion will be there, and troponins will be, elevated. Okay, so now the fourth number is STEMI. STEMI means the complete occlusion of the blood vessel lumen, resulting in transmural injury, complete blockage. Okay, and it is like the transmural injury and infarct to the myocardium, which is reflected by ECG changes and a rise in the troponin T or I. See, elevated troponin T's and hyperacute T wave or ST elevation, right? ST elevation or T wave elevation. Okay, T wave elevation or ST elevation. Usually STEMI is ST elevation MI, right guys? Understand? So, okay, should we repeat the troponin in case of continuous chest pain? No need of repeating the troponin T. Usually we should go for ECG, and if the doctor finds that it is a stable angina, then definitely we should go for stress cardiogram, stress echocardiogram, or the treadmill test, exercise tolerance test. Both are coming under the exercise tolerance test. Okay, so these are the four types of CADs: stable angina, unstable angina, STEMI, or anstomy. Okay, see now, look at this. These three, unstable angina, STEMI, and anstomy, comes under acute coronary syndrome because it can happen from seconds to hours, right? It can take from seconds also to develop the entire plaque, right? So that's why these are coming under the acute coronary syndrome. Okay guys, I hope it is clear. Now learning point 3 for you, how it actually gets developed, how the thrombus has been developed. So tell me, what is this pathway called? Clotting factors. Clots are there. Clotting is happening. So what is this pathway called?
Clotting cascade.
Yes, the clotting cascade.
Exactly, clotting cascade. But here, when there is a clot formation, clotting cascade is there. When there is a clot formation, when there is myocardial infarction, there is not only clotting cascade. There are two things. Okay, one is platelet and one is clotting factors. There are two things which are involved. So look at these two factors. Look at these two, cycles. Look at these two processes, and you will understand how the clot is exactly formatting. First of all, try to understand. It's very clear. It's very simple. I'll make it very, very simple for you. First of all, there is an injury. Okay, look at this star mark. This is the injury which has happened to myocardium due to free fatty acids, calcium particles, or any foreign particles, or maybe due to the surgical, due to the surgeries. Sometimes clot comes from the other part also, or maybe the catheters, when we pass the catheters from the vessels. There are multiple things which can cause the injury to the myocardium. Okay, so this injury happened due to any reason. Once the injury happens, there are multiple factors and multiple elements get secreted from the injured site. Those elements are VWF. VWF is von Willebrand factor. Okay, this is the main factor which starts the platelet adhesion. Von Willebrand factor. Okay, that is called von, VON, WILLBRAND, Willebrand factor, VWF. That is called von Willebrand factor. Okay, and then collagen, this blue color dot, you can see this is collagen. And there are the GP2B3A factors also. So you can see these dots are the elements, and these kind of arrow marks are the receivers or called receptors, which are available at the platelet. Okay, which are available at the platelet surface, which are circulating in your body. Okay, I mean in your body, in your vessels, platelets are circulating in the blood, like platelets are the one of the component of the blood. So when the injury happens, there are the secretion of VWF, von Willebrand factor, collagen, GP2B3A, and these comes out and activate, adhere to the platelets. These comes to the platelet surface and attach to their respective receptors. These factors attach to their respective receptors at the platelet surface. Once they are attaching to the platelet surface, they are activating the platelet. Activating the platelet means they are activating the thromboxane, they are activating the serotonin, epinephrine, and ADP inside the platelet. Okay, and once the platelets are activated, platelets will invite other platelets to come together and aggregate. Okay, these are calling all other platelets and aggregating. Aggregating means making a plaque, and that plaque is soft. It's very soft plaque inside the vessel. There is a very soft plaque which has been made by platelet adhesion. You can check out platelet adhesion, platelet activation, platelet aggregation. This is the process of platelets. Only platelets, right? Because of these factors, platelets are aggregated now, and platelets were activated and aggregated. Now here you can see platelets are aggregated, but at the other side, from the same injured site, there are the tissue factors which are releasing. Okay, tissue factors are also releasing along with von Willebrand factor, along with collagen, along with GP2A3B, GP2B3A, glycoproteins. Along with these glycoproteins, there are the tissue factors also which are releasing. Okay, those tissue factors are factor 7 and factor 9. Okay, so factor 7 is actually converting these converting these tissue factors into tissue factors 7. Okay, tissue factor 7, and this tissue factor 7 is converting factor 9 into 9A. 9A means activated. Okay, this factor 7 is activating factor 9 here. Okay, and activated factor 9 is activating factor 10, factor X. Okay, and this factor X, activated factor, the factor X is activated now. This is converting prothrombin into thrombin, and this thrombin is converting fibrinogen into fibrin, and fibrin will go to this platelet soft plaque and make it harder, because it will make a mess around the plaque. It will tighten the plaque. Okay, and then this plaque is kind of unbreakable. Okay, and then it will start restricting the flow of blood, right? That will start restricting the flow of blood inside the lumen of the vessel. I hope you understood this cascade pathophysiology of the clot formation. Okay, so here there are two processes. There are two different separate processes. One is platelet aggregation, the platelet cascade. One is clotting cascade. Understand, there are two things which are very, very much important in clot formation. One is platelet cascade, one is clotting cascade. Okay, so I hope you understood how the platelet and the clotting factors are making this plaque and making it solid, right guys? You understood? I hope it's clear. Great, thank you. So now let's go to this. Further tests were done. Echocardiogram was showing the regional wall motion abnormalities, left and right both. Okay, left and right both. Abnormalities, wall motion abnormalities means usually the heart wall has a motion. Okay, when there is an infarct, when there is an infraction, then the wall motion is partially stopped or completely stopped, completely closed. That is called akinesia or akinetic. Akinetic means there is no movement. Okay, why there is no movement? Because there is no oxygen supply, there is no nutrition supply to that part of the heart, that part of the wall, right? So that's why there are motion abnormalities of the wall. That's why that's how we detect where exactly it is, whether it is left or right heart, whether it is like anterior or posterior, like front of the heart or the posterior part of the heart, whether it is lateral or anterolateral. Okay, that's how we decide the location of the heart attack. Right, so here it is left and right both sides because LMCA, let's see. So, and HB here is 9.2. We must have remember that the patient had the pallor, right? Patient had the pallor, and RBC is TLC and RBC is normal. Serum creatinine after this has been raised to 1.9. Okay, the second day serum creatinine was raised to 1.9 from 1.4. So now, what do you recommend, guys? What should be done now? What test should be done now? We have done echo, we have done ECG, we have done blood test, blood test, biomarkers. What's next?
Kidney function test.
Kidney function test.
Kidney function is here. Serum creatinine 1.9. Done. Come on, guys. Heart attack. We are talking about heart attack. We are not talking about kidney. Angiogram. Angiogram. Right? We should do coronary angiogram. That is called CAG. Okay. Coronary angiogram. Coronary angiogram is to check the exact location and size of the plaque, where it is. Let's see. These are the results of the same patient. These are the results of the same patient from angiogram. Okay. So echocardiogram was showing regional wall motion abnormalities, and this is left side. This is right side. This is left side. Now check how it is. See, this is a normal right coronary artery which is supplying the blood to the right side of the heart. That is called RCA, right coronary artery. Okay. So here you can see the blood flow is normal. The size of the vessel, the perimeter of the vessel is normal. But here you can see one arrow. That denotation is saying that here it is blocked. Okay, you can see the flow of the blood is restricted here. You can see at the tip of the arrow, you can see the blood flow is restricted because there is a partial block. There is a partial block and the blood flow is restricted. That's how we can say the plaque is here. The infarction is here in the right coronary artery itself. Okay, size and all we will detect. Now let's come to the left side. Left side says there is a major block at left main coronary artery. Okay, left main coronary artery means here you can see the white region. That means it is quite completely occluded because till now this is darker, and here it is like no blood flow kind of thing. And then if you look at the LED also here it is having the white part. This is also blocked partially, and there is OM, but these are the branch vessels. The LCX, OMD, diagonal and all. These are the branch vessels. Main vessels are RCA, LMCA, and LAD. LAD is left ascending descending aorta, artery. Okay, left ascending descending artery, coronary artery, and LCX is left circumference artery. Okay, so these are the branches. These are the coronary branches. So main blocks are here. One is in the right side, one is in the LMCA and LAD. Okay, so LAD is again the branch of left main coronary artery. Okay, but this is also blocked. So usually these are the main arteries. Okay, so this is the angiogram report of the patient. Now what is the final diagnosis? Okay, any guess for the final diagnosis, guys? Any guess for the final diagnosis? Okay, so dyslipidemia, hypertension.
Acute coronary syndrome.
Exactly. Acute coronary syndrome with anestomy and double vessel disease it was. Why it is double vessel disease? LCX was blocked what? 55%, LMCA was 88%, RCA was 76%. Usually we go for stenting when the block is more than 70%. Okay, we go for the stenting when the block is more than 70%. We go for block removal and put the stent right now. Previously it was called as balloon angioplasty, where we just remove the the plaque, but there was no stent placement, there was no DES, or there was the bare metal stunts. Okay, I mean in the ancient era means the 20 years back, there were the balloon angioplasties, and there were the bare metal stunts. Bare metal stunts means there was no medicine, only the bare metal which was placed inside in form of stents. But nowadays there are DES. DES is drug eluting stents. So these stents are covered by the drug, maybe tacrolimus or some other drugs, and those are secreting the drug. Those are secreting the drug with the slow slow delivery. So they are restricting the plaque formation again, right? So that's called DES, angioplasty procedure. Okay, so the patient was anestomy, double vessel disease, because LMCA and RCA was prominently blocked. LCX was just 55%. So, and then anemia, iron deficiency or hemolytic, further evaluation was needed. Then CIN, importantly CIN, because the creatinine was raised from 1.4 to 1.9. So that was just because of contrast, because we used contrast to check angiogram, and then we did angioplasty, right? So guys, what are the differential diagnosis for this? You know now differential diagnosis. What is differential diagnosis? So what would be the differential diagnosis for heart attack, for myocardial infarction? List out all the differential diagnosis, guys. Please list out all the differential diagnosis here. What do you think is the common disease which mimics the heart attack?
Angina.
Hypertension and
Gastritis.
hyperlipidemia.
Oh, come on, guys, guess. Okay, we call it guess ban gayi hai. Gastritis. Gastritis is the most common differential diagnosis for heart attack. Gastritis is the most common differential diagnosis for heart attack, because it has the same symptoms. It has the same, parasternal chest pain, but that is quite different, because gastritis does not radiate to the left side. Okay, gastritis, GERD, yes. So let's check. Acute gastritis, acute mitral regurgitation, acute aortic dissection, aortic stenosis, anxiety disorder. Anxiety also have the similar kind of pains radiating to the left side sometimes. Okay, when you have severe anxiety or stress, you get the similar kind of chest pain as heart attack. So remember, you should not stress yourself too much. When the person is very much stressed, it gets the chest pain frequently, and they feel they're in heart attack, and they run to the doctor again and again. And what the doctors do, they go for unnecessary checks of angiograms and all everything. So you should not stress yourself too much, or every time you should not stress yourself too much. Anxiety disorder also mimic the same symptoms as heart attack, right? Okay, then the infective endocarditis, of course, has the same myocarditis, pneumothorax. Okay, so these are the major mimicking concepts mimicking differential diagnosis, right? So we have discussed sign and symptoms. Now guys, tell me, what are the typical sign and symptoms of heart attack or myocardial infarction?
Chest pain, shortness of breath,
Chest pain.
Chest pain,
shortness of breath,
chest pain.
radiating to the left side, shoulder, jaw, or the left arm. Okay, shortness of the breath with suffocation, or Maybe
Heaviness in chest.
heaviness in chest. Exactly, right? Okay, then what are the risk factors? You guys tell me the risk factors, all the risk factors for heart attacks.
Smoking.
Smoking, exactly.
Obesity.
Obesity,
Hypertension.
Atherosclerosis.
hypertension,
Conditions like
Hypertension,
diabetes,
AKI.
alcohol intake, hypertension, diabetes,
Diabetes mellitus.
dyslipidemia. Remember, guys, listen: hypertension, dyslipidemia, diabetes, top level, grade one factors: diabetes, hyperlipidemia, and hypertension. Then smoking, obesity, age, and alcohol intake. Stress, second grade, and the third grade are other problems.
CKD.
Okay. Sorry,
CKD.
CKD. I mean, CKDs are like in minors. CKD, cancers. Cancer therapy is again one of the major factor, major risk factor, because 80 to 90% of the patients may usually have the negative impact on the heart, whether either it is the radiotherapy, whether it's a chemotherapy, hormonal therapy, anything, but all the cancer therapies have the negative impact on your heart. Okay, so
Atherosclerosis, sir.
and family history, I forgot the family history. Family history is one of the major risk factor again. Okay,
Can we say atherosclerosis is also a risk factor?
atherosclerosis is hyperlipidemia.
Okay. Thank you, sir.
Yes. Okay. And what are the, just for your revision, guys, how heart attack, myocardial infarction?
Sir, can you please repeat the question?
How do you assess the myocardial infarction?
By checking
ECG,
troponin T.
troponin,
And raised
echo, risk factors, history,
Angiogram.
medication history, angiogram. Definitely correct.
raised
Okay?
cardio biomarkers like troponin T and troponin I.
Yes. Okay. Now, learning point 4, risk factors. As I told you, hypertension, diabetes, smoking, alcohol intake, tobacco chewing, hyperlipidemia, family history, respiratory problems, injuries, digestive problems, neurological problems, and infections. These are minors, and gender. Okay, these are major, these are minor, right? Now, anemia also is one of the risk factors. Okay, then initial treatment was given to the patient. Okay, tell me what could be the initial treatment, guys, when the patient is having heart attack. What could be the initial treatment according to you?
Statins.
Antiplatelets and nitrogen. High dose of aspirin and clopidogrel.
Nitrates.
Nitrates, vasodilators. Okay,
Calcium channel block.
calcium channel blockers. Is it? Gargi is saying thrombolytics. Okay. We're not discussing here thrombolytics now, but yes, if the patient, yes, if the patient is not reachable to the hospital, if you feel the patient cannot reach the tertiary care center within 4 hours, then definitely we should go for thrombolytics. Can you give me the example of top thrombolytics?
Enoxaparin.
Yes.
Enoxaparin.
Enoxaparin. No, enoxaparin. Why enoxaparin? Enoxaparin is not thrombolytic.
Anticoagulant.
That is anticoagulant. Yes.
Streptokinase.
Altiplase, tenectoplase, streptokinase, altiplase. Okay. Do you think the altiplase is the? Okay. Very interesting. Someone has written altiplase. Tell me the FDA approved indication for altiplase.
Fibronolite.
No, no. I'm asking what is the FDA approved indication for altiplase?
No idea, sir.
Stroke?
Voice problem, sir. Not not clearly, sir.
No. See, altiplase is the first choice and FDA approved thrombolytic agent for the stroke. Okay. For myocardial infarctions, usually we go for tenecteplase, streptokinase, urokinase. I mean, urokinase is secondary. We usually go for these two. Okay, tenecteplase and streptokinase. Okay, altiplase is for stroke, right? Yes. So here, usually, because this patient was to the tertiary care center in time, so we have to give the loading dose of dual antiplatelet therapy. Dual antiplatelet therapy. One is COX inhibitor, one is thienopyridine inhibitors. Thienopyridine inhibitors or P2Y12 inhibitors. That is what? Example. Clopidogrel. Exactly. Clopidogrel or now the recently
Prasugrel.
Ticagrelor. Canagrelor is not used in India right now, but canagrelor is another drug, which is latest drug in that family. Okay, so dual. Sorry, Prasugrel. Yeah. I mean, definitely. See, first line therapy. I mean, the first line drug, first generation drug was clopidogrel. Clopidogrel has high bleeding impact, high bleeding profile. So they changed some structures. I mean, they made some structural change in clopidogrel. They came up with prasugrel. But prasugrel has some specific regions, specific side effect profile. Then they came up with ticagrelor. And what's the difference between clopidogrel and ticagrelor? Understand it clearly, guys. Clopidogrel and prasugrel are irreversible P2Y12 inhibitors. Ticagrelor has one best quality, that is systematic and that is reversible. Okay, reversible means when we give the clopidogrel to the patient, it is bind with the platelets and bind permanently until the platelet dies. Okay, and ticagrelor bind with the platelet for certain time, and after certain time it will detach and the platelet will be refunctioned normally. Okay, that's why ticagrelor is the best and having the less blood less bleeding profile. That's why ticagrelor is recommended over clopidogrel and prasugrel, and that is the new generation drug. Okay, it was costly earlier, but after 5 years their what we say it here, the cost has come down a lot because their the policies and what did we say it, I forgot the term. That was patent. Okay, that was patent. That time the cost of one tablet was around 75 rupees, but now it is available in 25 rupees. Okay, because the patent has gone from the company. Okay, so now they the ticagrelor is very cheap. Okay, in the market, and they can it is easily available. Yeah, patent by AstraZeneca first. Remember, you're correct, exactly, Adnan. So dual antiplatelet therapy. So one antiplatelet in dual antiplatelet therapy is aspirin, because in the COX inhibitor group, in the COX inhibitor category, there is only one drug, and that is aspirin. Okay, so this is mandatory. And then in the second group, there is ticagrelor was given 90 mg 2 tablets, then atorvastatin 40 mg 1 tablet stat, and then acetylcysteine 600 mg 1 2 tablet. So can someone tell me what is loading dose and why we have given acetylcysteine to this patient?
Loading dose is 150 mg.
What loading dose is 150 mg?
Acetylcysteine.
It is 600 mg. No, I'm asking what is loading dose. I'm not asking about the ticagrelor or aspirin or anything. I'm asking what is loading dose. What do you mean by loading dose?
So the dose which is given initially to
Higher
maintain
doses
the
initially.
absolute concentration of drug in the body.
Exactly. Okay, that is called loading dose. And after that, we directly shift to the maintenance dose, which can maintain the concentration in the serum, okay, or the blood, or the your circulation, right? So the initial dose of aspirin is 325 mg, ticagrelor 180 mg, atorvastatin 40 mg, and acetylcysteine is given because we are taking this patient to the procedure, and once the patient is going to the procedure, to avoid the gastritis, to avoid the other gastric related problems, we give acetylcysteine. Okay, so this was given, and IV UFH heparin, definitely IV UFH heparin. Why? To avoid the peri-procedural bleeding, or to avoid the peri-procedural clotting. Okay, that clotting should not happen peri-procedural. Peri-procedural means during the procedure. So to avoid the complications during the procedure, we give UFH shots. Okay, UFH shots we give. Okay, and then definitely enalapril, because the patient was hypertensive, remember, and the metoprolol 25 mg. Why? Because patient's heart rate was high and BP was high. So we have shifted the patient to these two, enalapril and metoprolol, right? Now, this is the treatment algorithm that we can discuss tomorrow. Treatment algorithms, right, guys? And okay, so after that, the patient went the angioplasty. Okay, angioplasty means the PTCA, percutaneous transluminal coronary angioplasty, with drug-eluting stent to LMCA and RCA, because these are the two major arteries which were needed to place the stents. Okay, so DS was placed in LMCA, left main coronary artery, and right coronary artery, and then the patient was continued on ecosprin, enalapril. Okay, so very interesting. This enalapril dose. Okay, I'll discuss this tomorrow when we are talking about the prescription. Then we'll discuss this. Okay, guys. So the patient was shifted to enalapril and metoprolol, atorvastatin. This was the further management, and then okay. So prescription audit we'll do tomorrow. Yeah. Yes, guys. So questions for today. I'll be happy to take the questions from you. Treatment patterns, the guidelines I'll take tomorrow. The treatment algorithms normally, and the patient's management system. Why to this patient? Streptokinase was not at all given because the patient reached to the hospital in time. Okay, the patient reached to the hospital in time, so there was no need to give the antithrombolytics here, or there was no need to go for thrombolysis.
Why
but I'll tell when I'll be teaching the guidelines, that definitely will do that. Yes, someone has the question.
No, why acetylcysteine is given here?
To avoid the peri-procedural gastritis or gastric complications.
Thank you, sir.
Yes. Can we give GP2B 3A receptor antagonist? No. And why we should not give? You should find the answer for that. And guys, you should not find the answer for the last class also. You're not putting anything in the group. How can you do that? I'm putting my full efforts and you are not even bothered to answer the questions what I'm asking here. Come on.
Sir, it's
And if
very
you-
Sir, in group only admins can message.
In group only admin can message. So
someone was sharing some nonsense in the group. I remember. I'll open it for everyone today. Wait. Okay, I'll open it for you guys so we can discuss there. Okay, I'll edit the thing right away, otherwise I'll forget. Group settings, send messages, all participants. Done. Okay. Verapamil, why Verapamil you want to give? Why you want to give verapamil? Tell me. And what is the indication for verapamil? Every drug has its own indications. Verapamil is CCBs, and according to the newer guidelines of hypertension or MI, CCBs are given when the patient is having heart attack along with arrhythmias. Okay. Okay, so if you are okay, guys, I can take class on Sunday also. Yes, please.
So what about morphine in the initial treatment?
What about
Morphine for pain.
morphine? Oh, there is no pain complication, by the way, but morphine is usually not recommended now. I mean, it's not recommended. It is recommended in case of the procedures. Peri-procedural, definitely we go for morphine, but when the procedure is more than 30 minutes long and there are the high chances. Okay, so usually we give it to the patients. Peri-procedural. What is the best antihypertensive class? ACE inhibitors or ARBs? ACE inhibitors or ARBs? Best antihypertensive class. No, I'm not asking, I'm telling. ACE inhibitors or ARB, first line choice. If the patient cannot tolerate ACE inhibitors, then we go for ARBs. I'm not asking, I'm telling. These both classes.
Sir, beta blocker.
Beta blocker is secondary when the patient is having high, pulse rate or yeah.
Sir, is NSTEMI and STEMI are belongs to the vasoplastic or variant angina?
Sorry?
Is NSTEMI and STEMI are variant angina?
Variants of?
Are vasoplastic like variant anginas?
Yes, these are. So see, there are 4 types of heart attack. There are 4 types of infarctions. One is stable angina, one is unstable angina. Why we call it stable angina? Because the chest pain is, persistent, but troponin T's are not elevated and ECG is not showing the problem. Okay, only the problem which can be tackled by stress echocardiogram or stress tolerance test. Okay, that is called stable angina. Means the angina is stable, chest pain is stable. That is not acute. Okay, and unstable angina means when the chest pain is not stable, when the chest pain is continued. Okay, continued. Okay, that's why we call it angina. Angina is nothing but chest pain. Angina means chest pain. So the chest pain is continuous or not continuous, stable or unstable. That is also the type of infarctions only. But minor infarction where the plaque is not running or plaque is not ruptured or plaque is ruptured but not running in the vessel. Okay, that is stable and unstable angina. So these are the type of heart attack. There are 4 types of myocardial infarction. One is unstable angina, stable angina, and STEMI and anSTEMI.
So then what about silent angina?
Silent angina is stable angina. Because we can, okay, silent angina is, it is, sometimes it is a different thing because the patient does not get the symptoms. Patient does not get the symptoms, but they have sometimes suffocation, they have, some problems. They cannot, I mean, it mimics with the other problems. It mimics with the other problems. And patients sometimes do not get the symptoms, proper symptoms, but patient had, patient has the infarction.
Okay, sir. Thank you.
Thank you.
Sir, what is
Contraindications I'll discuss in next class. And if you guys are ready, I'll take the class on Sunday also. If you are guys ready, that's all.
Yes, sir. No problem.
Great.
Yes, sir.
Great. Okay. So take care, guys. Thank you.
Sir, Sunday you can take us.
Good night, guys. Thank you.
Thank you, sir.
Thank you, sir.
Thank you. Thank you, guys. Thank you very much.